And just before we get started, I know that we're all in different places, but I want to acknowledge our traditional territory where we're sitting. So we are in the traditional territories of the Anishinaabe, the Haudenosaunee, the Lenni Lenape, and the Attawandaron. And I'm very excited to introduce Jen Walker. So Dr. Jennifer Walker is a health services researcher and also an epidemiologist, and she is Haudenosaunee and a member of Six Nations of the Grand. She completed her PhD in community health sciences at the University of Calgary. I only learned that this morning, Jen. I don't know where. I thought you did your PhD, but I did not know it was Calgary, so that is very exciting. So Jen lives in Sudbury, which is a very beautiful place with her family. She has 2 young children, but she also at Laurentian University holds the Canada Research Chair in Indigenous Health. And to us, Jen is very special because she is a part of our mentorship network and holds the PI position, the principal investigator position at Laurentian University, where she's been, I think, responsible for doing a lot of very hard work to support efforts around community building or relationship building with communities, raising some really amazing scholars, and at the same time doing really important scholarship. So yeah, Jen works very closely with a number of Indigenous mentees and community organizations to support learning about self-determination of Indigenous peoples and communities and their health and their data and access to health services. So I just want to say thank you, Jen, for being here today, miigwech, Nyawen, and for supporting our learning and sharing your awesome work with us, because you're super inspiring and we learn every time we get to sit with you. So that's all I'm going to say. Thank you. You can take it away.
Thanks, Chantal. Thanks for all those words and for inviting me to do this. I was like, oh yeah, I probably have a presentation somewhere about epidemiology. I was like, I don't have a presentation somewhere about Indigenous epidemiology. So it was great. It was a good chance for me to really reflect on myself, actually, and my path and what it is about the tools and methods of epidemiology when grounded in Indigenous perspectives and frameworks that can be so effective. So I'm really grateful for this opportunity to come and to be with you. And if you don't mind, I'm going to take 1 second because the sun is shining in my face. And I just want to put my blinds down just a little bit. There we go. There, I will be more comfortable. I don't know if you can see me as well, but I don't have a sun shining in my face now. So thank you for coming. I'm excited to see that there's people here from across Canada. And, you know, I actually didn't know how much to assume about people's knowledge of epidemiology, actually, and those approaches. So I am really open to, I have my chat open. I'm really open to sort of like, you know, if there's questions along the way, please don't hesitate to ask. Also, if you're sort of like, yeah, we've all taken advanced epidemiology, we don't need you to be talking about it in this way, that's fine too. But if you do know a lot about epidemiology, just be patient a little bit at the beginning, because I just want to talk a little bit about some of the language that we use around epidemiology and what we use it for. But I think my main goal in this was to, you know, to kind of share a little bit about my journey of trying to understand epidemiology from Indigenous perspectives, and to really try and figure out a path of making that, of kind of bringing those two areas of myself, I guess, together. And so it hasn't always been easy. So I'm gonna share, if you don't mind, I'm gonna share my PowerPoint. which is only here to guide us. So if it turns out it's not helpful, then that's totally fine too. So as Chantal mentioned, so I did my epidemiology training at the University of Calgary. And the reason I did that was actually because I had gone to the University of Waterloo. I took health studies at Waterloo, and with the sole intent of applying to medical school. That was exactly where I thought I wanted to be, the contributions that I wanted to make. I ended up never actually applying to medical school because I think it was my third year course in epidemiology, and I was absolutely hooked. I was so fascinated by looking at patterns in populations to look at what is our collective health profile. What can we learn about looking at the whole population that we might not learn from looking at individuals? And so my path was really set, and I decided to go out to Calgary and do my graduate studies. So that's what I did. But when I was there, I didn't have a lot of Indigenous mentors, and I didn't know how to connect those worlds. And I remember actually talking to one researcher who, was closely connected, working with First Nations communities in Southern Alberta, who said, you know what, come back to me when you want to do something actually useful, because epidemiology is not useful to our communities. And I was so heartbroken, honestly, like I was so shocked and heartbroken that was the response. And so, I'm so grateful now that I have colleagues and we have people who have found their own paths and found ways to epidemiology and through epidemiology, because now you all have, more mentors you can look to and more paths you can look to. There's not just one path to how to do this. But it's a really important thing to have people to look to. So that idea that that if someone walks, I'm looking outside, there's a ton of snow. I don't know about where you are, but I have a lot of snow outside my window. And when someone walks in that snow, before you walk in that snow, you can at least see where the path is going. Even if you decide to go off the path a little bit, you can come back on, and it can just be a little bit easier to walk that path. So I'm excited to share a little bit with you about my perspectives on epidemiology. I decided to call this Counting What Counts because, epidemiology is a lot about looking at patterns and trends and in numbers, and sometimes you can get lost in that sea of numbers. I remember right when I was finishing my PhD in 2006, there was a publication that had this sort of great title that was like data everywhere, but not a drop to drink. It was like that water everywhere. But so it's like, we're swimming in a sea of data sometimes, but it's about finding those things that are really important to count in the ways that are important to do it. I thought I had my chat box up, but it's not actually. So maybe just interrupt me if there is something, because I'm not seeing it. I'm seeing people's faces, but not the chat. So I wanted to just give a little bit of an overview of what is epidemiology and why is it important. So that's sort of what I talked about. A little bit of the language and tools of epidemiology. And we can go into as much depth as you want to about this, but it's a fairly high level. A grounding in Indigenous perspectives around data and epidemiology and kind of population health research and what those impacts can be on population health. And sort of talking about where those points of opportunity are to learn from others and to work with epidemiology approaches and to learn more about how to do this. So I kind of think about this sometimes when I don't know if any of you do reading, But sometimes, and I'm like, I do it for fun, and it's really awful looking. So I'm not going to pretend to be a beader, but I grew up with that in my life, and have, it's like a fun thing to do for me. It's not serious. I just want to put that on the table so you don't think that I can actually do this well. But when you end up with the beads at the end and they're mixed up, and you've got this sort of like pile of beads that's a beautiful, sort of mosaic of beads, but there's not order to it. It's, you know that there could be patterns, that you could organize things so that there could be any number of patterns in these beads. You could organize it by color, you could organize it into rows, you could organize it into, patterns of color, or you could bead an image, like a floral image, or other kinds of images. So you have choices to make about how you organize these beads. You have choices to make about how you look for the patterns, where you start, and how to approach it. And I think of epidemiology like that, because what we have is whole populations of people, seas of people. You can sort of see the patterns of health and how those track with patterns of, exposures, or patterns of life events, patterns of, occupation, or patterns of shared experience. But it's really hard to see that unless you ask the questions to try and find that. So ordering and asking the questions is a really important role of an epidemiologist, deciding which questions to ask and how to order the information. So one thing that I've learned in the years since doing my epidemiology training is that we are not sort of neutral players in the process of research. So in epidemiology, I trained, at a medical school where we were really, it was almost atheoretical. We didn't ground ourselves in much. We sort of learned the methods in detail, did the stats by hand, really got into the depth of it, but really didn't really question ourselves and question the assumptions of science, the biases that might exist in how we decide to undertake the questions. And I think that's a really important component of your own awareness that you all have, that I didn't have for quite a long time. You're learning about things in a different way, with a different kind of framework and mentorship, hopefully, even by virtue of being connected to the Indigenous Mentorship Network. But this idea that you make decisions that bring meaning and life to data, you decide how to order things and which questions to ask, is a fundamentally important part of, to recognize actually as an Indigenous epidemiologist, because you have a lot of ability to make sure that the questions are asked in ways that are grounded in our understandings of relationality, you have, and that actually respect Indigenous sovereignty, and so we'll keep talking about this. So when we think about epidemiology, what excited me about it is that it's the study of our collective health, and collectivity, and our networks, our kin ties, our relationships to one another, to creation, to the land, to language, to our shared histories, is really what builds those patterns of health in our in our populations, in our societies. And I think that it's so important to look at the, what surrounds the health of an individual when you're looking at an individual. But it's also really important to look at what surrounds the health of a community or a population when you're looking at a community or a population. And so this is one part of making sure we have a strong understanding of what makes us healthy, what helps us stay in balance as individuals, is the study of our collective health and well-being. So there's sort of two broad ways, I would say, that epidemiology does this. And this is the really high level, like, you know, we're not going to get into study design or anything in detail like that, but just that the reason epidemiology is helpful and epidemiology approaches are helpful is that it helps us to look at the distribution of health. And you see that I'm framing it this way deliberately. I would say probably most of the presentations I ever saw about epidemiology when I was a student was about the distribution of illness. But I think if we frame it, you know, we can use our knowledge about what does, the kinds of things that do contribute to collective health is actually like seeing ourselves as healthy. It's actually part of our collective perception of our own wellness. And so looking at the distribution of health over demographic variables like, you know, like gender in all its complexity, like age, like, you know, things like those sort of shared experiences, like, you know, where people work or where people live, geography. So often you see epidemiology used to map, like the data is mapped, and that's an expression of the distribution of health over space, you know, where you see, you know, potentially clusters of cancer or clusters of, on the other side of that, oh, I do see something just pop up there. That people can look at those patterns over space, but also patterns over time. So looking at how you know, how we're doing over time when it comes to mental health. Especially if we, you know, we know that we've, you know, changed something about what we're doing in the ways that we address mental health. Looking at those changes and patterns over time is also really important. So the distribution is a big part of what the tools of epidemiology do. The other thing that epidemiology focuses on is the relationships between exposures and outcomes. So what the things that make us healthy and keep us healthy. So you can see how loaded, like these terms carry such loaded meanings, exposures and outcomes. You think of smoking and lung cancer and these kinds of things. But in much of the work that I do with community and guided by the priorities that that communities have, it's often looking at more positive outcomes, not always, but often looking at more positive outcomes and looking at those factors that make us resilient, you know, in terms of things like cognitive resilience. I do quite a bit of work around dementia and cognitive impairment. So what are those things that contribute to cognitive resilience or healthy aging? And, you know, what, even if someone is, you know, would on a scale be considered frail, they still represent their health. They rate their health they rate their sort of balance in the 4 quadrants of well-being as strong. Why would that be if you see someone who would check the box for unhealthy, but they rate their well-being as strong? What does that mean? And what can we learn about the perspectives that those people are carrying? How can we line up those beads to tell that story, to express that pattern that is there in the population that then we can learn from and we can strengthen? So those are the kinds of things that broadly the role of epidemiology in our sort of like in our broad thinking about what health and healthcare research can do. But you can see some risks here too. So I work, in addition to my role at Laurentian, I work as the Indigenous lead scientist at ICES, which is where health services data for the Ontario healthcare system sits and is linked all together. So someone goes to the physician's office and then the hospital and then ends up in long-term care. Those records are linked and you can track people over time, geography and demographics through the healthcare system. So I'm often finding myself in the position of advising other researchers who might not completely understand or be grounded in Indigenous perspectives on data and thinking about things as the questions about what makes us healthy and balanced. And what happens often is that, you know, sometimes they want to include Indigenous identity in a model to sort of control for it. These are risks that happen with the sort of application of epidemiology without understanding what we're doing as scientists with Indigenous data. Another risk that often occurs is that people like to map out what's happening across Ontario, for example. I know some of you are not from Ontario, but my experience is mainly with Ontario data and a little bit with Saskatchewan data. But mapping out the data over geographies, some of those units of geography can get down to the level that basically identifies communities, identifies First Nation communities. So you know that the vast majority of people who are making up that data, so that the vast majority of people are First Nations people that we're actually by default, telling the stories of these communities by publishing data about those geographies. And I think that these are things that we need to help people understand, that if we keep telling the same deficit-based stories about communities over and over again, then it's like, you know, I'm a little tired this week. I got a cold sore, you can probably see it. I'm kind of like if I'm feeling a little off and it's the end of the week and I'm tired and I come to work and absolutely everybody says, geez, Jen, you're looking really tired. Oh my gosh, you don't look well. Oh, you're kind of pale. The more times people tell me that, the worse I feel. And I mean, I'm not making light of it, but really, if over and over again, every report that comes out about a certain geography, which we know is all Indigenous communities, then that's really, it hurts. And we have to stop hurting people and communities by good intent. And so many epidemiologists and people who do that kind of population level distribution, looking at distributions, have this assumption that we are actually, many of us, taught that as long as our role as epidemiologists is to shine the light on problems and to be detectives and get to the bottom of issues. Sometimes those are not our issues to explore. Sometimes they're not our stories to tell. And sometimes our good intention of shining the light on issues just makes it so that people have no rest from our light. Like it should be more about shining a flashlight to try and find the paths we need to take to improve health and balance and healing and wellness, rather than shining the light on problem after problem. So if we think of our own disposition as Indigenous scholars and as Indigenous people who are trying to serve our own communities, then we have to reframe our role as epidemiologists so that our role is not to just point out problem after problem after problem. Our role is actually to shine that flashlight through a really dense forest and try and find a path, because that's what's needed. It's not continuing to shine those lights on the problem. I'm going to pause because I saw that there was I couldn't read them, but are there some questions already that I should stop and answer, Katie?
There is one question.
should I try and get there? I don't know how to do
We can come back to it after your presentation, I think.
Oh, okay,
yeah.
That's fine. I'll keep going. Yeah, as long as it's not something that is burning right now. So those two things, looking at distribution and looking at relationships, like I'm very broadly categorizing things right now, but we talk about incidence, which is the number of new cases of something over a certain time period, prevalence, which is the total number of cases of something over a certain time period. And so a lot of the work I do is actually still in that realm of looking at, actually on Monday, a paper about the incidence and prevalence of diabetes in First Nations in Ontario is coming out in CMAJ. And that was like, that's what the Chiefs of Ontario and the Health Coordination Unit of the Chiefs of Ontario wanted to look at. They wanted to publish and look at the incidence and prevalence of diabetes as one part of a bigger project that looked at many aspects of diabetes in our communities, in our First Nation communities, and among First Nation populations. So so incidence and prevalence of disease is still actually a big part of my work. And if you think about it, as much as we want to be striving to look at strengths-based outcomes, there's also looking at incidence and prevalence and the patterns that happen related to disease is also sometimes very helpful for communities who need that data for advocacy, who need that data for funding, who need that data for better understanding. So one of the things in communicating the results that happened was that we looked at the incidence and prevalence by sex and age. And when we were presenting it to health directors in First Nation communities, they were saying, listen, like our programming around diabetes in our community is really targeted at age 50 and above. Like the kinds of activities and programming and the people we invite to that, it's really for people age 50 and above. But look at the number of people and the rising number of people, young people who are developing diabetes. We should really be just those kind of simple shifts where you're like, okay, our programming it needs to be more inclusive of younger people. So there's really important information that can come from looking at those patterns that can help us to respond. And this isn't like far-fetched from anything that that our elders and our ancestors would have done, right? To plan for seasons, to plan for taking care of whole populations. So looking at those patterns and understanding what's happening is really important for taking care of our communities and our populations. When it comes to looking at the relationships between things, we have tools that we use, that measure correlation, that express relative risks. So if, the risk among women is this relative to the risk among men, so maybe it's 2 times higher or it's 20% lower, that's a relative risk. Odds ratios sometimes are interpreted in a similar way, but they're used in different study designs that we can, I'm happy to chat with anybody, or you're probably all having some exposure to this already. And so I guess I just wanted to just mention some of the language that's used around epidemiology. And I remember at the beginning of learning epidemiology, sometimes these things would kind of swirl around and be like, okay, what do we use in a cohort study? What do we use in a case control study? Why would we use a case control study over a cohort study? And just like those study design questions. And they still are really grounding in important concepts to remember. So if you're learning them now, and you think you might not need them later, you probably do. Like having a fundamental grounding in the concepts is really important. And being able to express what they mean. I think that's probably the thing that took the most practice, was after understanding the concepts, is being able to express what they mean. Because suddenly, if you're sort of like the age standardized odds ratio is this, that's not very meaningful. And especially when it comes to communities that may have smaller numbers. So I remember at one point, I was working at the Canadian Institute for Health Information. So I don't know if you know that organization, but it's a pan-Canadian organization that holds databases for the whole country. So like the data that sit at ICES that I now work with for Ontario level, many of those databases contribute into these large databases at the national level. And I remember we were doing these health indicators for small, sparsely populated areas. And people were coming back to us and saying, you're giving us a rate per 100,000 people, but there's only 30,000 people here. So we don't understand what this rate means when it's per 100,000 people, and those people don't, like there aren't that many people here. And so it was like, wow, okay, yeah, we really need to, and I mean, it doesn't seem that hard to get your head around that, but when you're used to churning out rates per 100,000, it really does take you back, and you're like, okay, well that makes sense, right? So we should be thinking about things and like being able to express what a prevalence rate means to this place, means at this time in this place with these people. And it's really good relationship building to be able to work on those things together. These are some of the mantras you hear. You can't manage what you can't measure, to justify all sorts of things, measuring things that you need to manage, and there's some truth to it. But the thing that I always ground myself in is this sort of counter narrative that not everything that can be counted counts, and not everything that counts can be counted. So when you think about the vast data that's out there, not all of it is important to track, right? It's really up to like us collectively. I'm not saying us as academics but us. It's up to us collectively to figure out what counts and what we need to track. And then it's also up to us to try and understand those things that we can't count and contextualize the things we can count in the things that matter that we can't measure at this point anyway. And I think of it sometimes when I think of this picture. This is my family. They're older now. So my daughter is now 7. And my son is 12, so they look so little in this picture. But this was when we were out for a walk one day, and I was like, look at all 3 of them are doing something. We're all sharing a space. We're all enjoying this, this spring day. So happy to be outside after winter, and we're all experiencing that forest differently. My husband there, he loves it when I show pictures of his backside in webinars. But anyway, he is looking at that log to see if it's too rotted for firewood. So he's like, what is happening with this wood right now? Is it still going to be useful? How can we salvage this wood? How much of it can we salvage? My son is probably feeling that log under his feet, and he's balancing on it, and he's looking for, where is it slippery, where could I fall, what would be fun, where could I jump off of this and freak my mother out. My daughter is completely oblivious to all of that, and she's looking at a toy that's hanging off of her backpack, but she's feeling the same space. We're sharing this space. What about this matters to each of us actually matters. Our perspective matters. So there are hundreds of thousands of data points in this picture. And when we were living it, there's even more data points. What does the air feel like? How warm is it? Is there wind? Is it moist? Is it dry? Is it, like, what does it feel like to be there? But all of us are thinking and caring about different things. And I just think that it's really important because, when it comes to, I often get questions from communities. They'll say, we want to understand, okay, actually, I'll tell a specific story. So one year I was at the Chiefs of Ontario Health Forum, and one individual came to me and said, we are serving a whole bunch of communities across Southern Ontario. We're a First Nations organization, and we address the opioid crisis. We're put together to address the opioid crisis. We're the small team. We're looking at supporting communities related to opioids. And so we want to ask of the data, how many kids are being born with neonatal abstinence syndrome? Because we're noticing that those kids who were born around 2010 and stuff are now, they're school age. We're having trouble figuring out how to support them and things like that. So we want to understand where it's going from here. Is it going up? Is it going down? What are we going to need to do to support that? So we started having questions about that. And so in my mind, I'm like, yes, we can get that number for you. No problem. So maybe I'm like my husband there and just thinking really technically about the data are there, which communities would you need? And then I'm thinking about the process of making sure that communities understand and support that data request. And, so we had a meeting to talk about it with the communities, 4 communities who had asked that question. And not all of them were able to be there, but the questions they had were much more in depth about support for families and schools, communities. And so their perspective was like, yeah, the data and understanding the trajectory, the pattern, the distribution is important, but we need to know where to go from here. We need to, maybe they're like my son, feeling that log beneath our feet. We're living this, and we need to understand how to move forward. So we can't just address questions solely with epidemiology. So we have now a study that has 2 arms, 2 branches really. One is looking at the data and questions we can answer with the data, and the other is looking at solutions in a qualitative way with someone else who understands qualitative research much better than I do, to look for those kinds of like understandings of even like supporting mothers and how do we support families and mothers and kids. So the perspective matters. The other thing that matters is sovereignty. So the act of knowing is a collective cultural and political imperative for Indigenous peoples. So the data and research about our peoples collected about us, with us, or by us belongs to us and must be cared for by us. And I think this is one of the key fundamental things when we're talking about how we move forward in using data that's already been collected or data that's newly collected. We have to really understand that it's not neutral, and that it has spirit, and that we need to be making sure it's cared for appropriately. One of the grounding things that I often turn to is the United Nations Declaration on the Rights of Indigenous Peoples, because there's really clear guidance that helps particularly institutions and researchers who might not have experience to understand that, that many of these things, it's not just a special interest group. We're not talking about, if we do it this way for Indigenous people, we're going to have to do it this way for everyone. These are rights. They're rights. They're the right to have self-determination is not a nice to have. It's a right. So we can't just include Indigenous identity in a model. We can't just report on Indigenous communities even though we weren't intending to. We have to be really critical about our own approaches and ensure that rights are being upheld. There's two conditions for data sovereignty, so it's leading me to this concept of data sovereignty. Those two conditions are decolonizing data and also strengthening Indigenous data governance. So those two things have to happen. So the data at ICES, those are very colonized data, right? So efforts to work on the decolonization of the data at ICES, the way we identify First Nations people is with the Indian registry. Like, how much more colonized of a data set could you possibly imagine, right? So we're using it for First Nations benefit, but we can't ignore the fact that we're using a colonial tool for identifying First Nations people. So when we think about decolonizing data, Maggie Walter puts forward 5 Ds of colonizing Indigenous data: disparity, deprivation, disadvantage, dysfunction, and difference. These things classify us as Indigenous people as problematic, and they're often used to rationalize dispossession, marginalization, and perpetuate narratives of dependency. So like what I'm talking about, those communities that we keep saying, well, they have this going on and this going on and this going on, they just really can't take care of themselves. We better take over their governance, you know. These actually can be very harmful. And so we really need to be cautious, and we also just need to understand what we're doing with data. This idea of data governance, so that was the second box of the two, is this interdependence of nation building and data building. So governance of data, so data sit at ICES, we need to make sure we have Indigenous governance of Indigenous data. We also need to make sure that Indigenous people and nations and leadership are using the data for governance, for nation building. So we need to strengthen our capacity as Indigenous people to use data. So I think we've actually done an amazing job in Canada at asserting governance of data. We have OCAP principles, we have strong Indigenous data governance in many cases. What we need to strengthen is the use of that data for our own governance, because that's the second part of Indigenous data sovereignty. There are groups around the world working on this. This Global Indigenous Data Alliance is a place I would direct you to, and you can see the website there. And there are networks around the world who contribute into this Global Indigenous Data Alliance. If you're interested in data epidemiology, they're much broader than epidemiology. They're all data, Indigenous data. They're a really good group to connect with. They just recently published, so there's these FAIR principles. Wow, this is really like hard to look at, it's too big. Sorry about that. So these FAIR principles that have been put out by Mainstream Research Data Alliance, this organization called Research Data Alliance, global organization, that data must be findable, accessible, interoperable, and reusable. And then in counter to that, this was actually a wonderful gathering in Botswana in 2018, the fall of 2018. We sat and we consulted and we began the development of CARE principles in response that talk about collective benefit, authority to control, responsibility, and ethics. So you need to, find there are these FAIR principles out there, but you can't use Indigenous data only in that context. These are additional things that need to be layered on when you're talking about Indigenous data. We've had gatherings across Canada looking at Indigenous data sovereignty principles, looking at whether we need to move a little bit beyond OCAP at this point, so that we're talking about also governance of data, governance using data. And there's been some really, really important thoughts that have come out of these things in terms of that real power that data and epidemiology have, but it's all about how this is communicated, connecting it to stories, connecting it to relationships. So all of those ideas about relational accountability that we ground ourselves in have to be there when we're talking about epidemiology as well. I was just going to mention OCAP, but I think people likely know OCAP, but it's essentially the rights for First Nations to own, control, access, and possess data that are about First Nations. And I'm speeding up, you can tell. I wanted to just mention the multi-layer relationships, agreements, partnerships that have led to the use of, or the First Nations governance of data at ICES. So essentially, no matter what source of data we're talking about that are that identify First Nations communities or individuals or organizations, those data cannot be accessed at ICES without First Nations governance. And that's been really hard for ICES scientists, I'll tell you, but it's been really effective at building the capacity of, when all of a sudden non-Indigenous researchers who are doing non-Indigenous projects who want to involve the self-identifiers, as soon as they realize that they can't just do it, then investments are made in building the capacity of First Nations to have a data governance committee that can review these applications. And so capacity has been built over the past 5 years in First Nations to be able to review applications, make decisions, assert governance over the data. Some of the things that have come out of this have been really impactful, actually, and I'd love to tell you more about them, and I will, but I want to leave time for questions. I just want to pause and say, though, that a few years ago, I heard about this partnership that was forming called the First Nations Center for Excellence in Epidemiology, and I was floored. I was so excited to hear that there was a First Nations Center for Excellence in Epidemiology. And then I was even more excited at the first gathering that I was invited to when they changed their name to Mamaway Yamawin, which means everyone's voices. Because I think there's no more fitting way to express what epidemiology is than to say it's everyone's voices. Because it's every one of those beads in that pile that comes together to tell a story, because it's everyone's data that comes together. And so everyone's voices represent epidemiology, and I just think that's beautiful. So I am speeding up. I just wanted to say that having these, so I'm talking about the one approach I'm taking, the path that I'm on, but there are diverse approaches to looking at application of epidemiology with community. There's the First Nations Information Governance Center. Obviously, hopefully many of you know that organization and is connected. Our Health Counts, led by Janet Smiley in partnership with many others and community partners, if you don't know, is a series of studies actually in urban centers where they're finding different ways of measuring strength, resilience, health, and as well as some of the outcomes that are useful for advocacy, and they have been useful for advocacy. They're finding different ways to identify people rather than using those sort of really colonial methods like the Indian registry. And so so that's a really important, so at Well Living House, the work that they're doing there has been really impactful. Places like the Aboriginal Cancer Control, I think it's still called the Aboriginal Cancer Control Unit, but at Cancer Care Ontario, other places like that where they're working with communities to answer questions about cancer. And also this, sorry, I don't know how to make that stop. Okay, just hung up on someone, sorry. There's an emerging graduate training program in Indigenous epidemiology. So if any of you are actually taking epidemiology and are not connected to this program development, then I would love to talk to you and connect you with the people who are developing it. And obviously also, probably most of you know that there's a Master's of Public Health at the Dalalana School of Public Health with an Indigenous focus, which is another place where there's some, you know, cultural grounding in epidemiology approaches. And she called back. So just to sum that thought up is just really thinking about learning from water. And that's how I think about that, is that I've taken one path and I'm traveling a path. Sometimes I enter others' paths and I come back into my own. And I think that what we're doing is it's more like a braided path, like these rivers that when I was in Calgary, I used to see them all the time, these braided rivers in the that go through the mountains, and that we're not all traveling the exact same steps, but that we're all heading the same direction. And so we're learning as we go, and we're learning from each other. And I just want to say thank you and open it up to conversations and questions. So I'm going to look at the chat. I'm going to let somebody know that this person keeps calling me. Just a second. Oh, okay. Okay, so okay, I'm sorry. I'm just going to text someone and let them know. Okay, I'm good. So should I just read the questions?
Sure, you can read it.
Okay, so one of them is, can epidemiological studies be done to support the efforts to fight corporations, industries, government in regards to environmental toxins, contamination, mercury, etc.? Absolutely, that's a really important part of it. These kinds of studies are really, so environmental epidemiology is sometimes complex because those kind of looking for those relationships in clusters is a bit complex, but it's very applicable. That's exactly the kinds of, these kinds of approaches can be really helpful. So it's a matter of making sure that the right questions are being asked and that there's people with the right sort of toxicology knowledge to be able to draw the right conclusions. But I think that this is exactly the kinds of tools that would be helpful. So there are fields of epidemiology. So I mainly do like aging work and chronic disease epidemiology, but environmental epidemiology is an occupational epidemiology. Those are a distinct field. And then there's also, I mean, how could I, not mention the coronavirus in the context of a talk on epidemiology today? There's, infectious disease epidemiology. That's, a little bit of a different approach, faster pace, but many of the same kinds of tools that are helpful. So another question is, can you expand more on the program you were speaking about Indigenous Epidemiology with Janet Smiley? So, this Indigenous Epidemiology training program that we're hoping and it's Janet Smiley who's leading that effort. So how it worked is actually she's partnering with people from across Canada so that we can develop a national program, and probably at a master's level, and it would be a master's of epidemiology with an Indigenous focus or Indigenous epidemiology. I'm not really sure exactly what. So we have some planning, a planning meeting in March, and with the full intention that we'll be able to move forward for you know, probably not this year's intake, but probably the year after. So this national program, she's quite optimistically working on, and connected through the newly funded NEARS. So many of the NEARS committed resources to supporting this program development. And so, and I don't know if, so all of you are in Indigenous mentorship, connected to either this Indigenous mentorship network or others, and those Indigenous mentorship networks will be sort of working alongside these NEARS, and that's how this program will be developed. So it's a little bit, there's not a lot known exactly about what it's going to look like, but that we've had a couple of planning meetings to begin the development of it, and working through the sort of like, it's not just one university, but yeah, but it's really happening. There's a lot of commitment around it. Another question just came in. I'm researching how land-based learning impacts Indigenous mental health in the James Bay area. Wonderful. I go into the social determinants of health that impact our mental health as Indigenous youth in my lit review. I'm finding it's difficult to be strengths-based, or I find the balance with such a serious issue, and I feel like I don't want to make light of issues that impact our mental health, like lack of housing, lack of access to clean water, discriminatory policy, etc. How do you find that balance? Because I don't want to hurt anyone by shining light on difficult issues, but also I have to justify why this research is needed. Oh, thank you for this question. It's a really great question. I think that we have to contextualize our current realities, right? And that context is in the context of determinants of health. You know, that beautiful book that's Determinants of Health, Determinants of Indigenous People's Health Beyond the Social, and thinking about those. So I think that it's sort of like recognizing where we are and the context and those discriminatory policies, all of those things that you said are really important to highlight. I think what's important is that when you are looking forward, you're looking at the things that contribute to mental strengths, like the strength of our mental health, our resilience, and things like that. And much of the literature is not that way. So a lit review is hard to do. Plus, you actually need to contextualize things. But I think the thing is that it's not that we want to pretend everything is all positive. I think it's just that conscious awareness that that the intention of our research has to be to help guide a way forward. And I think that that kind of balance is actually really hard. But so I really appreciate your comment. But I do think you need to contextualize things in that way. But it's also about just understanding your position of helping things to move forward. I'm looking, I see that the time is up. Seeing if there's any other actual questions. There was one that you gave me in advance, Katie, which was about the competencies and important things to know. And actually, I tried to focus my presentation there because rather than, so you absolutely have to understand like the technical aspects of epidemiology. That's like a given. You need to have those competencies. But it goes so much beyond that, because you need to understand your relation. You need to understand your relation to your own self, to your community, across generations. And I think that if we understand ourselves as having that role of, being of service and being a helper to our communities, rather than sort of being, we're helping decision makers have the information that they need to be able to make the decisions. So we're providing that much needed information to lead to better self-determination, stronger Indigenous governance, and healthier communities. And I think if you seeing yourself in those spaces, those are the competencies you really need. I think that's all the questions. I really appreciate all your really positive and welcoming comments too. So thank you for all of you who are contributing to the chat here, and it's really nice to meet you all. Thank you.
Yes, and I just want to thank you for hosting our webinar. It was very informative, and we're so fortunate to have you today. So, chi miigwech, Nyawen, and I hope everyone has a wonderful day.
All right, thanks. Have a good weekend.
You too.
All right.